Hello, everyone. My name is Chuck French, and I'm the Chief Growth Officer of Mutare, and I'm proud to be the moderator for today's AHA event. We're here to discuss an important topic, one that impacts each of us personally, as well as every one of America's hospitals and healthcare systems: robocalls. People sometimes joke that robocalls are one of the only topics that Americans universally agree upon. We just don't like them. They can be nuisances, but in a healthcare context, extremely dangerous. We're fortunate today. Our panelists for today's discussion are two of the foremost experts in the industry. They're active members of the FCC's Hospital Robocall Protection Group, and today they're going to educate us on this important subject. Together, we're going to learn more about the Hospital Robocall Protection Group, the challenges that robocalls present within healthcare. Here's some recommendations of what hospitals can do, and lastly, how to engage with law enforcement to report fraudulent activity. But first, let me introduce our panelists. John Riggi, having spent nearly 30 years as a highly decorated veteran of the FBI, serves as the first advisor for cybersecurity and risk to the American Hospital Association. John leverages his distinctive experience at the FBI and CIA in the investigation and disruption of cyber threats, international organized crime, and terrorist organizations to assist on policy and advocacy issues and provide trusted advisory services for the nation's hospital and healthcare systems. His trusted access to hospital leadership and government agencies enhances John's national perspective and ability to provide uniquely informed risk advisory services. In his various leadership roles at the FBI, he served as a representative for the White House Cyber Response Group and as a senior representative to the CIA. He was also on the FBI's National Operations Manager. He was the FBI National Operations Manager for terrorist financing investigations. He led the FBI Cyber Division National Program to develop mission-critical partnerships with the healthcare and other critical infrastructure sectors. John held this national strategic role in the investigation of the largest cyber attacks targeting healthcare and other sectors. He currently leads the national HHS Healthcare Sector Task Group to develop resources to assess the field in managing cyber risk as an enterprise risk issue. He launched a national campaign with the AHA and government agencies to help members protect medical research against foreign threats. Lastly, he also served on the New York FBI SWAT team for 8 years. John's the recipient of the FBI Director's Award for Special Achievement in Counterterrorism and the CIA's George H.W. Bush Award for Excellence in Counterterrorism, the CIA's highest award in this category. Thank you, John, for being here with us today, and thank you for your service. Rebekah Johnson is the CEO and founder of Numeracle. With over 10 years of regulatory, government, and compliance experience, businesses have leaned on Rebekah's expertise to guide them through the evolving complexities of maintaining successful call delivery and positive brand reputation in a changing ecosystem. She's an active member of the FCC's Hospital Robocall Protection Group, chair of the Enterprise Communications Advocacy Coalition, and member of the ADIS IP NNI Task Force, the co-author of the Shaken Standards. Prior to founding Numeracle, Rebekah served on the FCC's Robocall Strike Force on behalf of the Empowering Consumer Choice Working Group. Thank you, Rebekah. Rebekah, why did the FCC create the Hospital Robocall Protection Group?
Chuck, that's a good place to start because, robocalls plague everyone. And we already had the FCC's Robocall Strike Force. So we would think, why isn't that enough, right? There was a lot of activities that came out of that strike force with regards to terminating carriers, implementing analytics to monitor traffic on the network, protecting consumers, giving them, the power of choice to be able to block calls, mark them as spam and unwanted. And so the fact that this group was established really highlights the severity of the challenges that hospitals are facing, specifically to this issue with fraudulent robocalls. And it really has to do with the level of disruption and the type of attack that it can have, really related to not consumers, but we're thinking about patients and patient care and the ability of hospitals to provide that care. And there's a variety of type of attacks that are very specific to hospitals that consumers, while yes, annoying that we get these unwanted phone calls we really aren't facing the damaging results that a hospital can go through. So it was really good to see within the TRICE Act that, this isn't just the FCC saying to do it. The FCC was told to do this. So it comes from Congress, passed through the TRICE Act, telling the FCC, hey, we need to put an advisory committee together. We need to focus on specifically assessing the problems that hospitals face, and then what can hospitals do to protect themselves. And what I really liked about this particular group is that the TRICE Act was descriptive in who participates in this working group. And so it shows the forethought of what's necessary for us to actually solve this. We could tell the hospitals, here's what you need to do, it's your problem, solve it. But that's not the case. The result of our work together that I worked with John on included the voice service providers. There were some specific activities that they need to take, and it just brings awareness to why are we all in this together. And then the hospitals, I worked with John. John was the leader of the hospital group, which we'll dive into on what can hospitals do. There is some control. There are some steps that you can take to protect yourselves. And then I loved how we rounded it out with regards to the federal government. And that's where the conversations as we were developing this report really got interesting, and a lot of aha moments. And we bridged some gaps where they may have been from hospitals to the federal side. It's, the hospitals are supposed to be focusing on care, right? It shouldn't be their responsibility to have to manage working with the federal government and the FBI and, reporting. So I really respect the people that we worked with on this group, and highly encourage, it's not just another report that gets piled with the federal government. This one's actually very actionable and has some great, suggestions. So John, I think you're the expert here when it comes to specifically the types of attacks. And the first step to address any challenge that we might have within our own organizations is awareness. And I know that we would like to think that everyone who's listening is aware of the types of attacks that occur. The chances are they're not.
Thanks, Rebekah. Great to work with you on the commission. And I think you hit a couple of significant points. Instead of the government being prescriptive, saying this is what you need to do, they actually did take the time to receive input from the affected parties, both on the communication side and ultimately the victim they're trying to protect, right? So it's interesting you talk about what the bad guys. So these bad guys here generally may be foreign-based, but unlike in cyber attacks, not all of them are based overseas. There's a fair amount that are based in the United States and who may use robocalls for what they believe are legitimate purposes, but there's many who are involved in fraudulent activity related to robocalls. So we generally divide robocalls that impact or interrupt patient care and safety at hospitals in two large categories. One, those that are unwanted, but not necessarily illegal or unlawful. And then there are those that are absolutely illegal because they are in furtherance of some other crime, generally some type of fraudulent activity. So let's talk about one of the first categories that impact public health and safety, right? And that's, I think, the key point here. These are not economic crimes. When you make mass quantities of patient care disrupting robocalls, you're impacting not only the care of the patients that are in the hospital, but potentially risking public health and safety of the larger community. If the hospital suddenly becomes unavailable for the community and emergency services, or you're unable to reach your provider or physician, there's much broader impact. That's why this issue is so important. And to that effect, one of the first types of robocalls that we're very concerned about are these telephone denial of service attacks. TDOS, they're called. Basically, in this type of situation, the bad guys use computers to overwhelm a hospital's communication lines and interrupting the ability for the staff to communicate internally, the ability of the staff to communicate with patients, physicians being able to communicate back to the hospital. So that's a pretty significant issue, almost equivalent to the hospital's networks being shut down during a ransomware attack. And some of these attackers intentionally do this with extortion in mind. And we've had instances where they warn the hospital, we're coming after you, we're going to overload your system, your networks, unless you pay us. And I would say, based on my background, that is absolutely an attempt of commercial extortion, what we would say. And I would say with the direct risk to public health and safety, which elevates that type of crime from an economic crime to one that has potentially a threat to life or violent crime penalties associated. So that's a warning to anybody thinking about this. The FBI and other agencies will come after you as attempting a potential violent crime. The other crimes that occur with robocalls are these targeted social engineering calls, usually in furtherance, as I said, of some other type of fraudulent activity. So the bad guys will call and try to get a staff member of a hospital or perhaps even a patient's room, most despicably, trying to get the line of a patient in the room and then claim they might be from their health insurance company, or they are in fact another part of the provider network, perhaps a pharmacy or so forth. And basically what they do is try to con the individuals out of their personally identifiable information. Maybe it's their insurance plan number, maybe it's their date of birth, maybe their social security number. And then they would use that to conduct other types of frauds, whether it's fraudulent insurance, health insurance billing, or perhaps even stolen identity, and maybe they take out a loan or open up a credit card in that individual's name. So that's one really, I must say, is truly a heinous crime, because you may be taking advantage of a patient while they're incapacitated or infirmed, and they might be expecting a call from their insurance company. So often, then what happens as well is sometimes the bad guys spoof the call as though they're from the hospital, or they spoof a call calling the hospital, but pretending to be somebody from a pharmacy, some other part of the provider, trying to get information out. And then in my world, what I see a lot is these callers posing as somebody from tech support, for instance, for the hospital or some other tech company, and saying, hey, we're having an issue, your password might need to be reset. Maybe they've sent that individual a phishing email, which makes a screen appear, and then the bad guys know at that moment to call and say, hey, we're from tech support, we need your username and password to get into the system to reset. So you can imagine, right, if you give that away, the bad guys, those bad guys are mostly foreign based. They now have access potentially to electronic medical records of thousands of people. Huge issues for hospitals to deal with. And again, as I said, some of them are just unwanted calls, right? They're telemarketing services that disrupt patient care, interfere with patient services. So I'll stop there, Rebekah, turn it back to you. Those are the general categories of calls we're focused on.
Yeah, and the one that I actually have a personal experience to is the hospital impersonation one. And this goes back as far as, gosh, 7, 8 years ago. I remember I got my start in communications, actually focused on healthcare communications. So for appointment reminders or hospital notifications, medication adherence. And I remember getting a call from one of our clients saying, we've got to shut down all of our outbound communications. The FBI is here telling us to do that. And I was like, what in the world went on? And as we started to have a conversation around it, I said, well, I looked at your system here and we don't have any active calls going out. And they said, well, apparently someone is calling our patients. And what they had done is they got billing record information, knew how much they knew the patient went to the hospital. They knew how much the patient owed, so they called as though they were from the hospital. Why would a patient not believe that? No. Right? So, and that was the time whenever we were starting to put 2 and 2 together with regards to the data breaches that were occurring. We thought that that was maybe separate from these attacks, but it was no, those data breaches were the feeders for the information, like you said, on the social engineering side. Use that to get in, to get the data. It's a very hush-hush, quiet kind of attack. Nobody's really aware. But the damage isn't done until they start to leverage and use that information. And I know you and I were talking because one of the big data breaches that I remember was with Anthem, and they were actually, the CISO from Anthem was speaking at a healthcare privacy security conference that I was at. It was just fascinating, the story and the challenges that no matter how big you are, people always think like, oh, well, I'm a big company, I'm a big name, this isn't going to happen to me. So they let their guard down. And that was just during that time of where we had to become much more aware and work together as an entire industry to be able to protect ourselves. And data sharing was a huge part of how do we establish that, to share when these threats are happening. But it's just interesting because it can come in very little, kind of trickle in, but then the damage is so big, not only to the hospital, but to the patients of the organization.
Yeah, totally agreed, Rebekah. And what happens is there's layers of fraud, layered crimes. Basically, when they have key critical information about a potential victim, they exploit it to its maximum capability. Just as law enforcement or intelligence agency would take a piece of information and try to analyze it and use it to its fullest extent, bad guys are doing the same thing. So not only do they have your personally identifiable information, maybe to open a credit card, they're going to call you, especially when they have the specifics that lend credibility to the authenticity of the call. That goes a long way. And then say, yeah, we need to, in regard to your payment, right, we have some new instructions, or we need the collection on here. Insurance company didn't cover it. And then before you know it, we have lots of victims wiring information to bad guy accounts. So it is a tremendous issue as a direct crime, but as an enabler of additional crimes.
Yeah. And John, this just kind of reminds me of the conversations we had when we were first kicking off and starting with, the blank sheet of paper of, okay, write the report, right? It's like, what are the recommendations? And we couldn't help but just get away from all sharing stories of fraud. But from that, just in our conversation that we've just had, it started to become evident of how we have to structure this particular best practice and break it apart. And so within each one of our groups, so we had voice service providers, we had the hospitals, which you led that group, and then the federal government. And so within each of those, we focused on prevention, response, and mitigation. And so I'd like to jump into the voice service provider aspect of prevention. Why are the carriers involved in this when it seems like it's really the hospital should be putting up their guards? The reason why the voice service providers were added to this is you mentioned it underneath the DDoS attack with regards to spoofing, right? There's nothing, absolutely nothing that a hospital can do to prevent someone from spoofing their number. And this is where we have to have the voice service providers continue to implement stir shaken. This is not going to be a stir shaken conversation, but it's basically a caller authentication framework that the carriers are mandated to implement. And essentially what it's doing is it's putting the pressure on the voice service providers to prevent the calls, those fraudulent calls from even getting into the network. So it's a help to the hospitals if we can put, these are your perimeter, right? This is the perimeter type of defense, but that's outside of the hospital. They can't control the telecommunications network, which is completely anonymous. So when you think about what the voice service providers are doing, really simply put, they're removing anonymity from the voice network. And part of removing anonymity means that you also have to know who you're doing business with. So the carriers are responsible when they are bringing on someone to deliver outbound communications. They have to know who they are. Who are you working with? There are certain standards. And the FTC has already, from the enforcement side, made it kind of clear on what the expectation is. You should definitely listen to the Enforcement Bureau if you're a voice service provider on what the expectation is for how do you identify, who you're doing business with. So they've already been implementing that, and their June 30th is the deadline for submitting a robocall mitigation plan specific to this. So from the hospital's perspective, this is a good step. I'm really, really expecting, at least by next year, on that perimeter side of preventing fraudulent calls from entering the network, we should be seeing a decline. But that just means that there's probably going to be some other strategies that the bad guys are going to use to try to get around. So it doesn't solve all the problems for the hospitals, but they should be aware that those tactics and strategies are being implemented from the carrier, voice network side. So John, the next aspect of it was, let's dive down into the heart of what we really want to talk about, which is the hospitals. And with that same theme that we had within the report of prevention, response, and mitigation, Can you go into some of the details that we discussed with regards to prevention? And these are the responsibilities and actions that hospitals can take to protect themselves.
Yeah, absolutely, Rebekah. And before I begin there, I just want to seize on a couple of points you made. The bad guys will, in fact, implement countermeasures to any of our security measures that we take. So this is not a problem that can be solved by any one commission, any one group of recommendations, just as in cyber threats, criminal threats, violent crime. The bad guys are always thinking of how to evade our measures that we put in place. So this is a process. It's ongoing. And at least as we have implemented this process, if nothing else, it'll create what probably the first thing that's most important for hospitals to help protect themselves is creating education and awareness of this issue. And a lot of these attacks, these malicious calls, these fraudulent calls can be prevented if the staff is aware of the potential fraudulent nature of these calls. So the first issue is just train staff to identify and recognize the different types of robocalls and how somebody may be able to socially engineer them into giving information. These calls are only successful if we give them the information. So ultimately, at its heart, these type of calls, schemes, are psychological attacks. The intent is to deceive the recipient of the call into giving them valuable information. So in educating staff, training them to recognize the type of calls, and quite frankly, to be a little bit suspicious when anybody's asking you for sensitive information to be given over a phone or via email or in combination of a phone and email. That's how sophisticated they're getting. Even if it seems like they have some data points that may make this seem legitimate, question that if it is sensitive information. Of course, no one should ever give their password and username to any system over the phone, nor should they give sensitive insurance information, health information over the phone. Carriers, insurance carriers, hospital staff, and technical folks try to make that pretty clear. We're not going to ask you for sensitive information over the phone. No government agency will threaten you over the phone in terms of you must pay your bill and here's your wiring instructions, or ask you to provide sensitive information over the phone. So identifying those calls, ask them to send it via hard email, but they should report it, right? So if they believe they're receiving these calls, training them, educating them, they should look to gather the data on the call itself. So staff should be trained to document the date and time of the call, the number being dialed, type of calls, is it a recording, is it a live person, what did they say, so forth, what was the caller ID number identified. Protect the data, as I said, don't give out any sensitive information. And then there should be a plan or process in place for the staff to report this to the appropriate personnel within the hospital, whether it's the chief security department, telecommunications, preferably both, if it's a criminal act involved there. And then, having a process, a governance process in place to receive that information, to work internally to understand the origination of these calls, and then work with appropriate law enforcement and regulatory agencies and the voice service providers to help stop those calls. So yeah. I'll start.
John, I have a recommendation. Yeah, I was going to say, you said you were going to stop. I had a recommendation that those are excellent points. And there is a place, I would say, within the hospitals where this process can be defined. Like I mentioned, I used to work with HIPAA privacy and security. And so, look, hospitals know that they have to have a breach notification procedure. Part of my breach notification procedures included my data assessment. So even if, let's say you have a small breach and it has to qualify for when do we make it public, right? There's all kinds of reporting requirements around your data breach. That is the best place to go to establish your fraud breach. I mean, this is maybe not so much a data breach, but treat it like that because you've already got some established required processes. You may not have to do the reporting that would be specific to PHI being breached, But that evaluation process, you've already got all the proper people within the hospital identified of who's supposed to sign off on this, review it, and then make the decisions on what you do next. What you should be doing is updating those procedures to include the specific data you need for this type of assessment. And then I know what you're going to go into next is, what do you do with it? So you can almost create like a grid or a chart of, is this a PHI breach? Yes or no? Is this a fraud breach under the robocall issues? Yes or no? And then have that path of, okay, what do we do then as an organization if we have this type? And then you just keep repeating that process over and over, and your team will be, well seasoned and being able to execute that assessment quickly, because time is always a matter when it comes to this. Very specifically, when we get into that next part of bringing in the law enforcement. So I don't know if you have any other thoughts on that, but that's just kind of my idea of where would I recommend to put this process.
Yeah, totally agreed. There should be that governance process outlined again for breaches of data. In theory, these may be breaches of data, but not that require reporting under the Office of Civil Rights requirements for more than 500 individuals. But again, what is the impact here? What I have seen is that in some hospitals, they're failing to connect the dots, right? Somebody might be aware a patient received a call. Somebody else might be aware that a staff member received a suspicious call, not realizing that these might all be part of a related campaign by a sophisticated criminal organization to steal information from the hospital and or in fact use that to gain access to hospital systems. So yes, that evaluation and then the classification. Is this an unlawful call? Is it a nuisance call? As you said, the checklist, absolutely legal, compliance, security, telecommunications involved there. And of course, there is the aspect that if the information's actually been given by a patient or a staff member, now you actually have a crime. If they've given out information and it's determined to be to a fraudulent entity, the patient themselves will want some type of response from the hospital. The hospital has to examine as well what is their role, responsibility, and potential liability exposure if they're allowing these calls to come through to patients, and especially if there's been prior reporting. They need to understand what measures they should have taken or should be taking to prevent the patient from receiving these calls. So beyond the technical issue, there is a really business risk decision here as well, preventing that legal and regulatory exposure you may have for your patients and staff. So, Rebekah, would you like me to go into some of the mitigation tools, or would you like to carry on a little bit here?
No, let's. I think it's natural to go right into the mitigation aspect of it. Once we're aware, now what do we do?
Right. So, really, again, two broad categories here: what a hospital can do for mitigation once they understand that they're being targeted by these calls. Really, internal methods and then external methods. And then really try to understand within your telecommunications department, what are your own internal robocall blocking capabilities internally, then working with your voice service provider externally, what are their capabilities, but absolutely making your voice service provider aware of the situation. Again, it'll help them connect the dots if they see multiple hospitals or multiple organizations receiving similar spoof calls from perhaps originating same number or same technical information. That'll help them block on a broader scale. Again, identify those fraudulent disruptive calls, logging all that information, getting into telephony management internally, and then understanding what the availabilities are internally and externally to block your number being spoofed. As you said, Rebekah, you can't do anything about that internally. That's where you got to work with the stir shaken capabilities and working with the providers. Segregation of numbers, again, technical issues that you can do here. Identify the configuration of the critical and non-critical lines in a hospital. So just like you would identify critical data, critical assets in a hospital, identify those critical lines, and that's where you want to build at least your strongest defenses around those lines there themselves. And then again, once you've evaluated the calls, evaluated the event, then that's where you're going to try to implement those controls, again, internal and external, working with the voice service provider. And the plan, just like you would have a cyber incident response plan, which would encompass all the required entities within your hospital: legal, compliance, communications, technical folks, telecommunications, even your information security teams, you should have a similar, as you said, Rebekah, matrix, making sure that all those folks are notified appropriately, timely, and they have specific roles and delegation of authorities that they should check, because this will recur. And again, lots of these similar procedures are already in place in hospitals for breach reporting, for cyber incident reporting, in their general, even emergency management teams and incident command systems. So these are things that can already be leveraged. And then at that point, the decision should be made, once you fully evaluate the event, to contact appropriate state, federal, law enforcement, and regulatory authorities. I'll turn it back to you, Rebekah.
Yeah, and it just reminds me of, this really is no different than the security measures that you put in place for your network. You don't establish usernames and passwords and put, perimeter controls and then not monitor the activity on the network. To me, that's the component that you just covered, is, essential to network security event management, right? Monitoring the logs, setting up what you want as alerts, and then that team is monitoring those alerts. And then you can investigate them to see if there is action or additional, data that needs to be gathered. I think we're careless. We're really careless if we're not implementing that aspect of it. You just can't lock the door and walk away and hope that nobody comes in. We have to do constant monitoring. So leveraging those types of services that allow you to create your own specific. You're going to find that every hospital is going to be different. They're going to find that the way that they're being attacked is different. So your security team should be a part of this. It's just going to be different tools and what they're used to. But the framework of how do you implement a security plan for your organization always includes some level of monitoring. And so you've got to be able, from that perspective, like you mentioned, the monitoring of the type of traffic that's coming into the hospital, the conversations. Maybe you have some agent recording, perhaps some AI can be pulled off of that as well on the conversations. There's just a lot of ways that you can do that monitoring. But then, like I said, the next step after you have the monitoring is, okay, now what do we do? So if we've fully assessed it, we've identified we've got a problem. Let's say that it is the hospital impersonation based on what we've seen. We can kind of tie some elements together. So what does the hospital do now that they realize, okay, yeah, we have a problem, something kind of on a grand scale has occurred. Am I alone? Like, how do I fight this? What do I do? What are those next steps that the hospital can take to protect their patients and themselves, and maybe help shut down the attacks as a whole?
So again, as I think I was talking, first let me expand on a couple of points you made. I think that are critical, is understanding your own network, just as we would understand it in your information technology network. What does normal activity look like, and what is abnormal activity? Often there are clues or hints buried in that data that the hospital already has, that they're being subject to attack, or what we would say is pre-attack reconnaissance, surveillance. So even in robocall areas, they may be some probing of the network, some isolated calls, which could be indicators of a broader campaign. And we call that concept too, like threat hunting, intelligence gathering, fright from your own organization. Of course, information sharing is critical within the hospital. I received a call here, that was strange. This department received a call. What's the threat picture look like there? And then external information sharing as well between hospitals, so within the sector, and then of course cross-sector, because some of these same bad guys are not specifically targeting just hospitals. So if they're involved in an illegal robocall campaign towards hospitals or healthcare, chances are they're also targeting other industries. So it's very good to have these information sharing channels open. One of the channels that I always recommend is a information sharing group called InfraGuard. They are sponsored by the FBI. All the members are vetted, and it is basically an all-hazard information sharing organization. So a hospital administrator may be sitting next to somebody in financial services or energy, and they can exchange relevant threat intelligence between the organizations. Best of all, it's free. And so it's a big advantage. And again, you get the direct input also from the FBI alerts and bulletins. So again, a lot of the controls I spoke about there, internal controls, external controls, education, awareness, incident response plan, knowing how to respond to these plans, and having designated points of contact within law enforcement and regulatory agencies, both at the state and the federal level. But again, I think the initial starting point is really the education and awareness of staff, and then understanding your technical telephony environment to begin with baselining that.
And I know we talked about in the group, underneath that telephony management was segregation of numbers and the critical versus administrative. And I don't know that we, I personally don't know, but I'd be kind of curious of how many hospitals actually take that approach to segregate the critical lines versus administrative, and if anybody within the telephony group or the security group at the hospital is even aware of that. So it's almost like an inventory kind of step perhaps needs to be taken. But I thought that was kind of interesting. I can't remember who contributed that portion to our best practices, but it just kind of made sense. Like, why don't we keep our critical lines protected? I mean, we do the same thing with data, right? Certain data that I have on my network is protected and segregated in a way different than data that's not needed to be protected. So we should do the same thing for phone lines, I believe, too.
Yeah, I agree. And most organizations do, in fact, have those high priority numbers segregated or identified as part of their continuity of operations plan. And so hospitals have to be prepared, right, to operate even during natural disasters, hurricanes, fires, floods. So they have that system pretty well organized, but often it doesn't take into account action by an adversary who's trying to defeat those lines, right? A lot of these emergency plans, fire, flood, tornado, hurricane, they're designed for natural disasters, continuity of operation, not somebody who's actively taking a role to try to defeat segregated measures. And unfortunately, as we have seen even very recently, last week, this week, cyber incidents can shut down all voice communications in a hospital. So here we have a different adversary. Their objective is ransomware. And one of the first things, the collateral damage effects, is that since it's VoIP, voice over internet protocol communications, when the computers go down, voice communications go down. And it causes a major issue for the hospital's ability to provide continuity of care, and quite frankly, is it definitely a risk to the general broader community. You have to divert ambulances, you have no communications with patients and physicians, becomes a major issue. So they, in summary, I think they have them identified, Rebekah. They can put controls in place, but if the broader infrastructure goes down, then those controls will not be effective.
So what is a hospital to do, or what are the best steps on coordinating with federal and state agencies, and how do they know when to engage with that? I think that's the part where things, I know for me, become a little bit more cloudy on what exactly do we do, and who really. Sometimes it feels like, does anybody really care about this problem that we're having? Like, will they care that we're having an issue? Do we sound like we're just complaining about robocalls? Kind of talk to from your side, because I know that you've worked on that side of, the collaboration and the coordination that is there with the federal and the state level of what do the hospitals do now that they have this information and need to tell someone. What's been that experience?
Again, I think it's incumbent upon the hospital to identify the calls, the nature of these calls, right? That they're actually being victimized by disruptive or unlawful calls. And then I think it's important for the hospital, the next step is to document the impact on that the call has had on care delivery. It makes a much more compelling case for when they do go to the regulators and law enforcement and say, look, these calls came in and they tied up our nurses' station lines. And as we were waiting for lab results and we were waiting for other information and trying to communicate with patients to tell them to come in for elective surgeries, or suppose you have a very significant lab results you're trying to communicate to a patient, and you can't do that in a timely manner because your phone lines are unavailable because of this. So I think documenting the impact to care delivery disruption, and then just like as we recommend for any type of incident response planning, is really the time to have those conversations with state, federal regulators, law enforcement is before an incident. You don't want to be in the midst of a crisis trying to figure out who should I talk to, and who do I trust to talk to? Who do I have that personal relationship within the government that I can relay this, that it will not generate some onerous regulatory audit upon us, and we don't want publicity. We don't want this to go to the media. Who do we trust? So just as in a cyber incident response plan, those trusted contacts in the appropriate agencies should be identified, actually listed in your incident response plan, and they should have a copy of your plan as well. So that's what I would say. Make sure they're identified prior, make sure they're available during, and then continue the conversation after the incident to make sure there's appropriate follow-up and emphasis placed on the incident.
And John, I think just naturally, I am seeing the logo over your shoulder there, and it, you know, and your experience that, you know, even from AHA, this, how serious they took that with bringing someone like you and your background and experience into the association to bridge that gap. So I would assume that, you know, a great place to start is with AHA with regards to how do we engage?
Thank you, Rebekah. I appreciate that for that plug for us. But yes, any hospital, member or not, I always make myself available for any hospital or healthcare entity experiencing any type of attack. I'm available literally 24/7, and I do give my cell phone number out actually to folks, and if they need to contact me. But for now, I'll just say contact me at jriggi, R-I-G-G-I, at aha.org if you ever need any guidance or assistance on this type of issue. And old habits die hard. I monitor stuff 24/7.
Exactly. Well, look, we got a question that I think is kind of timely with what we're talking about right now, and I'm going to take an approach at answering it. And John, you may have a different angle from it, and Chuck, you too, you could join in if you know the answer. But it's with regards to the denial of service attacks into a facility, and the fact that a malicious attacker can come into a telecommunications system with a multitude of inbounds, basically IDs that they're using on their numbers. So ultimately, how can a hospital or a department protect themselves from an attack where they're using different numbers each time? It'd be a lot easier to just go, oh, this number is sending 1 million calls, but it's not that case. It is a multitude of numbers. So Don, I don't know if you want to go first. I have ideas on where that needs to be fixed, but Chuck, you're on mute.
Yeah, I have some ideas as well.
I figured you might. So John, I'll let you go first and we'll go to Chuck.
Yeah, so as you alluded to, right, difficult issue, especially if they have automatic programming that's constantly changing the numbers. They can attempt to block internally the numbers, but if they're rapidly changing, it may in fact overwhelm their internal capabilities. That's where they've got to get a hold of the voice service provider immediately, and then explore what other technical tools that both Chuck and Rebekah you might be aware of to help identify and block these mass wave of continuously changing numbers. But let me turn it over to Chuck or Rebekah.
You hit on it. It's the velocity of the calls, and there are solutions, and Mutare does have one of them where we can monitor the velocity of the calls coming in, and you know it's simply an algorithm, and you can triage those calls as they come in, and control the speed that they come into the voice network. And so that's, you know, whoever had asked that question, that's something we would certainly be able to engage with them, because we can sit between the carrier and the voice network to address that, and what he's describing or she's describing as a TDOS type of attack.
Yeah, and then I would add on to once you are aware of that, and let's say you're working with Mutare and they have information, honestly, one of the next things you should throw it over to is not only all the other federal side that we've mentioned, but to stop the activity is engaging with the Traceback group, and that's run under the U.S. Telecom, and they can then, they've got the authority to go knocking on the door of the voice service provider who is facilitating the delivery of the traffic. And that's a way for us to get down to the identity of who is the one that's actually implementing this. If it's overseas, it's going to be a little bit more challenging, but if it's something local, we can at least at a minimum get that service provider who is provisioning that traffic onto the network to stop. Chances are they probably have some really bad practices on who they're selling their services to, and they might be facilitating other types of attacks. So this is a great question, because I feel like this question really covers why it takes so many This is not just the hospital's responsibility. It requires voice service providers. It requires analytics monitoring providers like Mutare to be involved to really truly shut down and stop this type of traffic. Eventually this should go down to the enforcement aspect, and there should be a fine, or at least prevent it from ever utilizing these types of tools again. But it's not swift, it's not quick when it comes to the enforcement side, but I have been very pleased with the activities of the Traceback group and the successes that we're already seeing in that group.
Rebekah, thanks for that. I just wanted to expand on one point that you made there, that really there are so many similarities between telephone denial of service attacks and what we call in cyber world just denial of service attack. So again, overwhelming the information networks with unsolicited requests for information. And just as in to protect information technology networks, there are service providers that specialize in denial of service capabilities that'll prevent those attacks from launching. Like the voice service providers offer that, or the internet service providers offer that for organizations. So that's what I mean. Sometimes you're going to have to, you most likely would have to rely on an outside organization to have that technology block in place to help prevent these type of issues.
So I'd like to ask a little forward thinking, because experts in their fields can do predictions, right? Or at least have a vision on where we're going. John, I would just be curious with regards to, what do you see the future of? I feel like we're getting into a really great phase of awareness about this. We're talking about it. No one's being quiet in their little silos. There's a lot of activity on the voice service provider with removing anonymity in the communication network. Do you have any predictions on what, year 2, 3, 4 looks like for communications and the strategies that we're implementing?
So I think the strategies are necessary and timely. In terms of forward-looking, I think they're just going to have to expand, and the interagency cooperation among the government will have to increase, and then of course the cooperation between the government and the affected entities with industry, both on the voice service providers and the potential targets of these attacks are going to have to increase. These type of attacks will only continue and will probably increase in frequency and severity if we follow the same trend as we've seen in cyber attacks. And the trend that we've seen also related to cyber world and other frauds is that bad guys are learning they're going to leverage all types of communication platforms and all types of technology to enhance their attacks. So I don't see this problem going away. I unfortunately see it increasing, which will require more sharing and more efforts like the HRPG.
I'll give my little prediction of, I think what we'll see, so whenever I first started getting into the privacy security space, I don't know, I stumbled into it in my career. I don't know that I was, back in the day when I was in college, that security was just a chapter in my computer science book. And really focused on the healthcare side. And one of the things that I saw out of that was the collaboration and the communication. I didn't understand until then when I saw, wait a minute, we're all actually better together when we're fighting the bad guy. So I see that, just an expansion, at least on the voice channel side, that we're all better together when we're all fighting the same common enemy. I do have concerns about strategies shifting and changing via different communication channels. So not only do we communicate with patients via voice, but there's text, there's email, and we're also using other social media type communications. And we've already seen, and I'm actually kind of joining that one as well with the content aspect of, WhatsApp and Facebook and Twitter and all these other elements, is it's a way to connect and commit fraud. So I think we just need to be aware of all of our communication channels within the hospital, not just the voice of, those are the ingress and the egress of messaging. And I think we should definitely be aware of, changes in strategies and tactics, because I think they're going to hop around and we might see an influx in different types of fraud being taken against the hospital via their social media too. So I'm hopeful that on the voice channel, it's going to really improve, because if we can at least prevent people from spoofing someone else's identity, that's a massive win. But John, to your point, that they're just going to change. So I think we should always stay in a state of awareness and don't get lazy with your security. There is never a moment when you can sit back and relax. There just really isn't. You should never take that approach. So,
Agreed, Rebekah. And then again, I think the other point I think we both touched on is not to treat each risk in each communication channel as a separate threat or address it in a silo. So understand that your text security, your SMS messaging security, telephony security, your email security, they're all related, because the bad guys will leverage multiple channels as a way to self-accreditate the veracity of their calls. I said, oh, I sent you an email. Did you get that? That came, it's actually a phishing email, spoofed email, or we sent you a text. A lot of folks don't realize how much phishing, or what we call vishing, occurs over text and voice in combination with a, in worst case scenario, a phishing email that contains malware on it, where they want the bad guy, they want the staff, the bad guys want the staff to click on it, which then delivers ransomware, as we've seen this tactic, and then shuts down an entire hospital, causes ambulance diversions and cancellation of surgeries.
Mm-hmm. Absolutely. I see we have another question, which I think we have time for, and I really like this question. This one comes in as, and I'm going to agree with this person. I feel as though the local telco service providers make it so difficult in combating spoofed and spam callers. As a customer, we need to track the calls, and only when it becomes abusive, we then need to file a complaint with the police department in order to solicit call data from the PSTN providers. Is there any efforts in trying to make this process easier for the end customers? I'm going to, relate to that with regards to, the local telco service providers make it so difficult. I don't know that they're trying to make it difficult. It's just not their role. Sometimes, they found themselves in this position of having to be some kind of enforcement arm or do investigations, and they're a telco provider. They've done their part, right? If they've established the telecommunications channel flow. This is why we have the US Traceback Group to specifically do the investigation. That group is established, and I love that the FCC actually, in a very nice way, nudged service providers to participate. It means that you're going to participate in raising your hand if you're the one that's originating that traffic. We don't need to go hunting you down. You need to be a part of this group if you're going to be a good player, at least in the United States. As a telco service provider, then you need to participate in the Traceback Group so that we can address these complaints. So I do think, though, that we need to get a little bit more organized, and I do work with the Traceback Group. I can provide other contact information specific for them, and they absolutely have the heart of wanting to streamline this and make it very simple for reports to be sent to them and allow them to quickly evaluate the traffic and get down to who the perpetrator is, the bad guy, whoever's servicing that particular traffic. So I think your challenges will be removed, but we have to understand that the Traceback Group is still kind of new and they are getting established, but I'm sure they would love to hear your feedback on how to make it much more streamlined. But I do give, sometimes some great things come out of the Hill, and that is a very good one with the establishment of that group, and US Telecom's doing an incredible job of supporting that too. All right, Chuck, I think we are down to closing unless we have any other questions.
I don't see any right now, Rebekah. John, did you
Chuck,
want to mention anything?
Yeah, Chuck, first of all, I'd like to thank you and Mutare for sponsoring today to get this valuable information out. You've been really supportive. Rebekah, thanks again. Always a pleasure to work with you and tap your knowledge there. Fantastic. And Chuck, as you know, we don't at the HA specifically endorse companies, but we certainly welcome organizations such as yourselves that are in a position to help our members and to help hospitals. And as I understand, as part of your support to help America's hospitals defend against this problem, you have initiated a free assessment, risk assessment for AHA members. We appreciate that, and we would strongly encourage our members to take a look, evaluate it, and see if that's right for you. Chuck, if you want to explain a little bit about what that assessment is.
Yeah, absolutely. We call it a voice traffic analysis, or in our parlance, a VTA. And there's no charge to American hospital association members. That's one of the things John was able to extract out of us for this event. So it's an additional benefit to each and every one of you who are on this call. And what it does is it gives you for the first time a quantitative look at your specific voice traffic in a way where we're analyzing every one of those calls that are coming in. And what we need in order to create this professional board level quality report is really call detail records. You send them to us, and we can get you information. There's actually, I'll turn the slide here. There's information down at the bottom of the screen about how you can get, learn more about the process. But send us your CDR in CSV or Excel format, as much data as you like, and we'll turn it around in several weeks and be able to educate you on what we find and what's happening in your hospital. So we'd love to conduct that for each and every one of you to illuminate whatever's happening. Because right now, for most hospitals, it's very anecdotal. We get a lot of calls, or someone's complaining about, calls, or that event that John was talking about happens. This is a way to get in front of that and see the data for the first time.
Appreciate that, Chuck. It's going to be very helpful for our members. We appreciate your support.
Oh, it's a pleasure. And by the way, I found this session really valuable. As I watched the two of you as members of the FCC's Hospital Robocall Protection Group talking about everything you've learned in your experiences. I didn't know what I was going to learn. I made so many notes on my end as I'm sitting here today, and a lot of things resonate. Right? It's a continuous process. Point solutions aren't going to solve the problem. You need a layered approach. It's likely going to be unique to your hospital. This is all very important, and with these distinct takeaways. So thank you both for your participation in this. I hope that the audience found it valuable as well.
Thank you, Chuck. And I'll just say from Numeracle's perspective, it's been really interesting to see the approach that Mutare takes, specifically for hospitals. I don't actually sit here and focus on hospitals with regards to my role in solving this. Numeracle's role is putting identity into the network. And I was just really impressed and actually quite thankful that somebody was specifically focused on the hospitals. I miss being in that space of focusing on communication strategies and improving patient care. So it was just comforting to know that someone had picked up the responsibility and started providing some services. So thank you for doing that, because you guys started that and went out on a limb that maybe we should probably do something. So way to respond to the call.
Thank you.
Thank you.
All right, with that, I think we'll wrap it up. There will be, you can see who your participants were today. Reach out to us, and we'll make available a recording of this as well if anyone wants to go back and listen. But thanks, everybody. Have a great day.
Thank you, Chuck. Thank you, everybody.
Thanks, everyone.